Maria here for our last presenter of the evening. And I want to tell you a little bit about Maria. We've known her for many years. We actually did a few mentorship cases together as well. And we've been kind of pushing her a little bit in her immediate implant journey, just a little bit. But, she's been asking all the right questions. We review a lot of cases together. And at the end of the day, I'm really proud of what she's been able to accomplish in her practice and also for her patients. So again, just super excited to have her here to present her cases on immediate implants. So let's give her a big round of applause.
Good evening to you all for the final time. And I am the last presenter for the day. And there's a saying, save the best for the last. And the reason for me being last today is because I was the last member to submit my presentation. So that's the reason. Today my topic of discussion is on how I have incorporated immediate implants in my practice. I will be sharing a couple of cases that I initially started off with. I have a guided implant workflow and a trio scanner with which I take impressions for the digital guide and for the crown. The first case is a 49-year-old healthy male who wanted to replace his lower broken left premolar. At that point in time, I was not very familiar with immediate implants. All I knew was socket graft, get the patient back in 4 months. Sorry. And this is the socket grafting that I had done. The patient came back 4 months later, and he had pain in his 3/6, so root canal was done. The patient said, now give me some more time and I'll come back in a while. Patient came back almost a year later and said, I'm all ready. You can go ahead with the implant on 3/5 and a crown on 3/6. We took a CBCT and lo and behold, this is what we saw on the CBCT. There was a huge infection here on 3/6. Now I had to make a decision whether to extract or re-treat this. I spoke to the patient and gave the patient options. And patient decided to go ahead with the extraction because he said he didn't want to retreat it. We were anyway placing an implant in 3/5. The most important thing I've realized while selecting cases is patient expectations. Have an open communication, explain to them the pros and cons, under-promise, over-deliver. So that's exactly what happened with this particular patient. He agreed and we went ahead for implants. Implant on the 3/5 and an immediate implant on the 3/6. This is the guided report because I do a lot of guided surgery, just like Reena. And these are the impressions, the CBCT files are uploaded, and this is the surgical stent. This is the day of surgery. Atraumatic extraction of 3/6 as much as possible. I first started off with the extraction of 3/6. The surgical guide placed, the hyosin implants, ET4, the healing abutments, the jump gap filled with bone, the membrane, PTF sutures, double interrupted sutures. This is just a slide showing how I extracted the mesial and the distal roots. I love using the long surgical round diamond burrs to debride and clean the sockets, just like one of our colleagues said. Clean, thoroughly clean until you see real white. So that's what I did. The pre-op x-ray over here, where the 3/5 implant went in, the 3/6 that was extracted, these are the 2 implants with the healing abutments. I usually love taking pictures on the day of surgery, 1 week post-op, 1 month post-op, and 4 months. 1 week post-op, what I usually like to look for is the sutures, whether they are in place, the oral hygiene. Stress with the patients not to trouble the immediate area site, keep the tongue away, at least for the first 6 weeks. Check on the healing abutment. 1 month later, I like to make sure the site is healing well, they're maintaining oral hygiene, the sutures are removed too, and I usually take an x-ray to just check what's going on with the bone. This is 4 months later when the patient comes in, and I've removed the healing abutment. This is the emergence profile. This is for 3/6 and this is for 3/5. I'm sorry, it's the opposite. And like I said, since I have the trio scanner, I use the scan bodies, that's the one over here, to take impressions. The scan body replaces the impression copings that you all use. And the most important thing while using the scan body is the flat end surface facing towards the buccal. I have tried to show it after taking impressions that it's more towards the buccal. The second important thing is once the scan bodies are placed, you take x-rays to make sure that they're seated really well. And these are the crowns, scrumentable Shaw zirconia crowns, custom titanium abutment, 2 of them that I usually get them done from Shaw Lab. The occlusal view, the buccal view, and the finished case. Happy patient, happy dentist. Patient is now motivated to do his upper 1516 next year. Case number 2, a healthy 53-year-old female who comes to me with a chief complaint that her lower left molar crown has chipped. You can see the chipped out here. That's all that was there. I take a preoperative x-ray and look at the amount of infection that's there. Again, the patient was asymptomatic. I told her, let's send you in for a CBCT. She goes in for a CBCT. So this is the infection over here. What I liked and saw was the inferior alveolar nerve was far away from the tooth. I mean, I had enough of space even if I had to clean the infection. This lady came to me around 2 months after I had done my first immediate implant. I'd asked Azim, what do I do? And like Azim said, he said, you want to do it? Do it. Just make sure you man up, pull up your pants, and get going with the case. So I decided to take this case. I spoke to the patient, kept her expectations really low, told her I'd try my best to remove as much infection as possible, and if nothing happened, I would just bone graft it and call her back. These are the guide reports, and this is on the day of surgery. This is how it looked pre-operatively, the surgical stent, the sectioning of the roots, the mesial and the distal roots removed, atraumatically as possible. Again, the long surgical round diamond burrs to debride, clean the sockets well, the implant placed, the socket, the jug gap filled with the bone. I did have to place a membrane for this. This is the preoperative x-ray, the roots being extracted. I put this x-ray because I just wanted to show I really had a tough time extracting, especially the mesial root. Ultimately, I had to just bury it out with the burr. This is the implant placement, and these are the scan bodies. The scan healing abutments that just came into the market way back, I think it was November 2022. This was a 6x5 mm healing abutment. I knew I needed a longer one, but since I didn't have it in stock, and I asked Azim what could I do, he said, just make sure you replace it, but you wait for 3 months, and that's what I did. So 3 months later, this is the 6x7 healing abutment. I just put the x-rays here together. This is 1 month post-op, 1 week post-op, 1 month post-op, and 4 months later. This is how the healing abutment with the 5 mm height looks. That's why I needed a longer healing abutment, and this is the 6x7 healing abutment. These are the impressions. Now, when the scan healing abutments came into existence, this scan healing abutment replaces the scan body. The scan healing abutment serves 2 purposes. The first purpose, it acts like a healing abutment, and the second, it acts as the scan body. So in essence, when the patient comes, you just scan it, just like that, with the scan healing abutment. The only thing is, when you're using this, you need these scan body carriers. They're specific to the kind of diameters that are used. So for example, if I had used a 6x7 mm scan healing abutment, I need to buy a scan body carrier of 6 mm. So these are the impressions taken. They go to the lab. They come back. This is on the day of crown delivery. I remove the scan healing abutment. This is the emergence profile, the crown in place, cemented, and this is the final x-ray. The third case is a 70-year-old patient with controlled hypertension. She came to us because she had a broken lingual wall. She had secondary decay, a huge a huge MOD, amalgam filling, and a necrotic valve. It was decided to extract this tooth because she didn't want to keep it. There was a lot of work that was going to be done. Sent in CBCT, got the workup done to get a surgical guide report, and this is on the day of surgery. The reason why I put this particular case was because this is the surgical stent. In this particular case, though it was a lower first molar, I found 3 roots, and that was unusual to me. Like a colleague just said previously, read the scan, listen to be learned. I did go back to the CBCT, and very vaguely on one of the axial slices, I did see the 3rd root. So this is the mesial, this is the distal, and this was the distolingual. Mind you, it was in the distolingual side. The implant is placed, the scanned healing abutment, the sutures in place, and this is the final X-ray. Again, 1 week post-op, 1 month post-op, and 5 months post-op. These are the digital impressions taken, again with the scanned healing abutment. So I just scanned it, sent it across to the lab, the emergence profile, and this is how the crown was placed. My last case for the day is also an interesting one. He was a 35-year-old healthy male who came in with a fractured crown at the gum line. This is a hopeless tooth, and he wanted to have an implant on it. Sent him for the same workup, a CBCT, got the surgical guide done, and this is on the day of surgery. Now, having done a couple of cases, I got a little ambitious and thought, why not we trying to get into temporary abutments? So I don't do chair side because I don't have the experience. I'm sorry. Sorry about that. I don't have the experience, so I got it done with the lab star itself. They sent me the surgical guide and the temporary crown with the abutment. The surgery went fine. The extraction was a bit difficult again because it was a root canal treated tooth. I got the implant in. I got a decent initial stability. But the issue was when I tried placing the abutment, that's when I lost total stability. It just spun. And that's because I didn't have the skills and I wasn't prepared enough. But like I said, always under-deliver. I told the patient if it happens, I would give it to him. If not, I would just bone graft it. So that's exactly what I did. I just socket grafted him, got him back in 4 months. This is the healing in 4 months, the buckle, the occlusal view, and the implant placed. I used the same surgical guide, by the way. This is the scan healing abutment, the PTF sutures. This is the healing 1 week post-op, 1 month post-op, and I'll be seeing him in Jan to place the crown. So all in all, I just wanted to tell you from this case, I under-promised, over-delivered, but in this case, I under-delivered. But because I didn't commit much to the patient, communication was open, the patient was completely okay with it. And my final slide for the day is the implant workflow that I follow in the dental office. Patient selection is of utmost importance. Make sure they have low expectations, speak to them, talk to them, tell them all you know about immediate implants. It may not happen. Informed consent, under promise, over deliver. Case selection, I'm seeing myself doing a lot of the lower molars, especially the first molars. Make sure they are asymptomatic, the shape of the roots, that they're not eye lacerated. Intraoral photographs, x-rays, a CBCT, assess the CBCT, read through your CBCT, that's most important. If you have a scanner, use them. Upload those files. You've got the STL files and the DICOM files in Canary. Labstar makes wonderful surgical stents. Set aside surgery date. Make sure you get your surgical guide on time. 1 week post-op. 1 week again, you're looking for healing, sutures, and reinforce to make sure they do not disturb the immediate implant site. 1 month post-op is usually for suture removal, and like someone mentioned, the healing abutment sometimes gets loose, so most often I do tighten it, just make sure during that time. 4 months later, digital scans again, either with the scan body or scan healing abutment, crown delivery from Shaw Lab, and final pictures. I take most of my pictures with iPhone. I want to thank Hyalson team. They're wonderful, they're extremely dedicated, they're always there to help you, and to Shaw Lab too for the excellent service that they always give. And finally, I'm incredibly thankful to Dr. Zine for being my guiding light in my implant journey. I hope I have imparted the knowledge I have from immediate implants, and that you are able to incorporate more of immediate implants and add value to your practice. Thank you.
Awesome. Very impressive. Very good. Very good.